Acha, acha. Now it is Nadeem sir.
Now it is showing as Nadeem sir. No sir, there it will come.
Correct.
Share option will come for you.
Okay.
So all set?
Yes, sir.
Right, so we start. Well, good evening, everybody. Welcome to this evening episode of Nephropathology, which is 8G. And we are streaming live from Manipal Hospital, Bangalore, via Kolkata. And today we have a very special topic, which is a slide seminar on various nephropathological cases. And we have two eminent people here. First, let me introduce the moderator, Dr. Dept, who is an MD from SCB Medical College, Cuttack, a senior resident from PGI Chandigarh, PDCC Nephropathology from PGI Chandigarh. Presently, he is an associate professor in pathology in JIPMER, Puducherry, with multiple international and national publications. He is the moderator and he will be introducing the speaker. Before I ask Dr. Debashish to take over, let me request all of you to please keep your mic muted. Please keep your camera off and please don't share your screen. With this, let me request Dr. Debashish sir, please take over and introduce the speaker. Thank you so much.
Thank you, Nadeem sir. And welcome all to this special session of special cases in nephropathology. It will be a very interesting session in the sense that the routine topics are very boring when we are talking a didactic lecture kind. And if anybody else of you have heard Dr. Mahesha before, you will be really excited to listen to him, because I have had occasions to listen to him on the dais. So it will be a very interesting session of 15 cases around. He will be presenting in different, like it will be classified into different spectrums. So it should be easy for you to follow. And as like Dr. Mahesha is like my elder brother, who is like little senior to me, and I know him from PGI days when like I've heard of him that he used to be good and great. So he is right now a consultant nephropathologist and head at the Manipal hospital. And he has got a beautiful lab. I promise that if you go to his lab, you will never be disappointed to see those slides, the sections, the stains, the quality of stains, the quality of slides. I have become a fan of his after visiting his lab. Once I saw those sections, which were much better than, like I would say, like maybe a little bit better than PGI and JIPMER also, what we practice or what we take sections and all. So after doing his MBBS from Hubli, he did his MD from PGI. Then he did a fellowship from PGI in Nephropath, following which he went to US also for some time, and he did a fellowship in again a kind of observership in nephropathology for a year. And then he's also like you can say he trained in clinical nephropathology for a year in the ISO certificate course. That's an online course through which he is certified. And he has his field of expertise in mostly in nephro and nephropathology related, like you can say urogenital pathology or nephro-uropathology. And he has many awards to his credit, like establishing the excellent center of excellence in Manipal Hospital, nephropathology lab in Manipal Hospital. And he, in addition to that, he's a guide for the fellowship, nephro fellowship course, as well as he's a member of many societies like the ISRTP, IAPM, and the Karnataka chapter also. And he boasts of many chapters in nephropathology textbook. And it is really a privilege, Mahesha sir, I would say, to introduce you to the listeners. And I hope and expect that they will definitely find this very interesting, and it will be a great learning session for them.
So you just have to press present now. Dr. Mahesha, please start. Yeah. Your entire screen. Yeah, fantastic. Yeah.
So very good evening to all of you here. It's an honor and pleasure to be here in the Neelam's lecture series. And Dr. Devashish, thanks for those kind words. I hope I'll not disappoint you or any other in the audience section by having the interesting cases that I've come across in my career so far here in the Manipal hospital. Before beginning, there's just a disclaimer as usual. My sincere gratitude to all the faculties in various departments in PGI Pathology, Chandigarh, who have trained me, nurtured me, and the mentors in nephropathology. Each of them are unique in their own style of teaching. Dr. Joshi Maman, Dr. Ritamra, Dr. Arthur Cohen, and Dr. Cynthia Nast, and Dr. Sudarshan Ballal and his team, where I interact with most of the nephrologists. I'm surrounded by a very good number of nephrologists here in the Bangalore. Thanks to all of them, I have learned the clinical relevant part of nephropathology, clinical relevance, while discussing with all of the nephrologists here, and we do conduct the kidney biopsy round and get to learn more things. This is another extended family where we learn each other in annual settings of meeting of the renal pathology and transplant conferences. Last held was in 2019. Unfortunately, the 2020 was withdrawn because of the COVID. We hope that with the vaccine, we get to see face-to-face in the upcoming conferences. So nephropathology is all about the handling the tissue, the renal biopsy material, and the interpretation, which is reasonably set in the background of clinical presentation. So both of them are tied to each other like husband and wife. In isolation, it makes no sense. And another factor would be to interpret in terms of activity and the prognosis of any given lesion. To have all this, we need to address certain points like adequacy of the tissue or adequacy of the clinical information that is provided in the clinical form, so that both of them put together are interpreted in the right context. So I'll be dealing with most in all these cases which I have selected is more pertaining to the diagnosis in the next 1 or 1.5 hours. So please bear with me that it may go up to 1.5 hours. Have a cup of coffee or whatever you feel like to be alert and not doze off. So to begin with, the clinical patterns, where we get the clinical history from the nephrologist who does the renal biopsies to look for the comorbidities and the symptoms that the patient has, like the renal parameters or the systemic symptoms, the list which is given at the bottom, and further to the information that is gathered from these, they are categorized as nephrotic or a nephritic, or just asymptomatic hematuria or proteinuria, and RPRF, acute renal injury, and chronic renal failure. So, so all these clinical patterns, these are color coded to the lesion that is expected in the renal biopsy. As you see here, if it's a patient with a nephrotic syndrome, these are the clinical differentials. So it's left for the renal histology to show us what is the lesion per se. So the interesting cases that I have selected here is basically forming this outline. So I don't have a particular set as an outline for the talk, but the interesting cases I have selected keeping in mind that whichever has gone in for a deep step serial sections or a special stains which has some unusual staining character, so that we learn new things, or if there is a lesion which is unexpected, completely blues of view from the renal histology, which is new to the nephrologist or even to us, and some cases where you need further clinical information or lab results, or you want to read a textbook when you see something which is very unusual. And the other would be like if you're encountering in a rare lesion, you would like to have a second opinion, so that you're convinced that what you're thinking is in the right line. So you take the opinion of your colleagues. I have here Dr. Kiran with me, who is again a nephropathologist. So whenever I have any difficulty, like he also shares, and we exchange the ideas. And also now it's the social media, we can always go back to the social media or WhatsApp group, we share in the images and seek opinions. And the third would be where we have a limitation of core biopsy. So how do we overcome this challenging scenario of with a limited tissue? So I have grouped all these cases, next 15 cases, in terms of what the ritual used to be in our department in Chandigarh. Like some activities would be there on all the weekdays. I have listed on the right hand side, and the cases are grouped in such a manner. If anybody is new to this lecture series of Neelam lecture series, I would recommend you to go back and listen to these wonderful lectures given by Dr. Subhadip Mitra and Dr. Debashish about on the nephrotic, the basics, the terminologies, the patterns, and all those things. And to have this in continuity, the article that I've chosen for Saturday, like it used to be 8 in the morning, and in that cold weather in Chandigarh, it was very difficult to enter the general club room before 8. It was always after 8, just sneaking through the door and find out where we could be seated. So the article is in the line with the previous lectures on the basics and the approach. This is one of the article which kind of standardized manner of reporting and the interpretation of renal biopsy, which Dr. Sanjeev Sethi, with his vast experience, has come across. He has put his thoughts and has come up with this interesting manuscript. I would recommend everybody to read this article, be it on the pathology side or on the nephrology side. The residents should definitely read this. The 5 cardinal questions that he has put in this manuscript is: what is the diagnosis? How active is the lesion? Is there any ATN along with the lesion per se? And on the other side, the flip side is that how bad is the renal parenchymal injury, like in terms of having scarring, and based on this scarring, is it worth giving a immunosuppression as it was in the acute stage, or is it too late to treat? So believe me, these are the questions which we all, as a nephropathologist who are practices renal pathology, would be given these 5 questions from the nephrologist, so that makes a meaning for performing the kidney biopsy, and the intent to look for what's the diagnosis and how do we manage further. So the two slides from this article is about the primary diagnosis, and this heavily relies upon the immunofluorescence. So whether the immunofluorescence is showing IgA nephropathy or a full house, or if there is any IgG and C3, or if there is a IgG within the mesangial region. So based on all this location and the type of immunoglobulins or complements, we would further segregate this in terms of immune complex or a C3 glomerulopathy, following which you need electron microscopy or a complement assays to further tease out these. And if none of them are above the threshold of 2+, then it is assigned as an ANCA associated GN, and clinically you would want to modify based on the results of serologies of ANCA, whether it is PR3 or MPO positivity. And similarly, the anti-GBM, which would be lighting up in the immunofluorescence, and when you consult the nephrologist and say that it is a case of crescentic which is quite active and IF shows linear, then they would want to immediately treat rather than waiting for the serum antibodies of anti-GBM. So such is the importance of renal biopsy in terms of management of GN per se. So, and the pattern of injury, the second is that of a pattern of injury, which goes on to say that what is the kind of proliferation and the location of these proliferation, whether it is mesangial or endocapillary or even extracapillary, and if there is any sclerosing component associated with these active lesions. So the SLE being the prototype of autoimmune disease will have a multiple patterns. So those are the clues that one would be hinted towards that dealing with the autoimmune disease. And there are different scores or class gradings, so that whenever nephrologist sees the report that this is the activity score of pertinent to the IgA nephropathy, like in terms of MEST scoring, or in the lupus it's ISN-RPS classification, to follow with based on the immunosuppression that they could, or even like class 3 or class 4 on one side and class 5 on the other side. So the treatment approaches are different for each of the classes. So additional modifiers, additional findings in the pathology like ATN or interstitial nephritis, or even arthroembolic disease. So ancillary studies, we do all this in terms of subclassifying the IgG as 1, 2, 3, and 4 to see whether it is a primary or a secondary disease process based on the subclass. And immunohistochemistry for DNA JB9, and sometimes we do this enzyme digestion of paraffin sections, so that to reveal the masked antigens, or if there is no immunofluorescence score, then we'll have to end up with doing the IF on paraffin section. So the last part would be that of a grading of chronic changes. So again, this is from Dr. Sethi's earlier article on how to score each of the individual departments, so that there is uniformity across the lab, so that the nephrologist who sees the report will get a sense of how aggressive he should be in the dosage of immunosuppressants. This was about the article. Coming to the Friday session, that was used to be at 2 o'clock in the afternoon, a renal biopsy round. There would be around 6 or 7 cases where the cases would be projected on the board, and the nephrology, we also do the similar way. The nephrology resident would interpret, and the clinical, the pathology resident would be taking questions from the nephrology side. So it was a crisscross Q&A between the two departments. So I have 8 cases in this biopsy round kind of thing, which has a theme. I'll come at the end. This is about a 40 years male who has nephrotic range proteinuria of almost 8.5 grams per day with a serum albumin of 3 and having a normal renal function. The serologies were all negative with a normal sized kidneys. So this was a scanner view which had a major chunk of it was the medulla, and from here you can see that there is a representation of cortex, and in this same H&E slide you can see that there is one glomerulus in this entire core. So at the high magnification of this there is it's the PA stain, which shows that some mesangial region is appreciated apart from the normal cellularity in each of the mesangial area, and the endothelium is normal. However, the basal membranes are standing out. They are very stiff and they appear thickened. So in the immunofluorescence also there was one core, the one glomerulus in the core, which showed positivity of uniform granular pattern of IgG in this glomerular capillary walls. So it was mainly staining along the walls. So based on this light microscopy and the immunofluorescence, a diagnosis of membranous glomerulonephritis was made. And further to it, in the current era, like in the last 1 decade, the dynamic, the primary antibodies or the primary antigens of MGN has changed to a greater extent. It would not stop at the membranous with the immunofluorescence of IgG and C3. Now we have the array of immunohistochemistry to further tease out the primary antigens. So in that, the PLA2R is one of the antigen, and this is the immunohistochemistry which basically highlights the same area of positivity along the capillaries which you had seen in the IgG immunofluorescence. So this goes on to say that it is a PLA2R membranous glomerulonephritis, which is primary antigen mediated. So this is what I was referring to. Once the diagnosis of membranous nephropathy is done, as the usual antigen is PLA2R, first you do the IHC for this or the immunofluorescence, whichever is done at your lab. If it's positive, then you assign that as a PLA2 positive membranous GN, or if it is negative, then it opens a Pandora of various, like with the patient a child, where you would like to see this SEMA3B, or if the IgG pattern is global, which I showed you in the previous slide, or if it is a segmental, then it has a connotation for, it could be a NEL1 antigen. These two subgroups can be associated with malignancy. So, this is a wide array of algorithm based for membranous nephropathy. So we'll move on to the second case. I can have the questions at the end of 8 cases, or if you feel like at the end, anything is fine for me. So the second case is about a 76-year male who presented with RPRF, and the ANCA serology is negative. The complements are normal, and he had some chest symptoms for which the CT thorax was done, and it revealed a right mid-lobe cavity. So cavitatory lesion along with RPRF, and the bronchial alveolar lavage is negative for TB PCR. So the biopsy was done in the hindsight of differentials of RPRF. So this is the core at the scanning view. What you see here is all represented by the medullary tissue. There was no cortex sampled in the core that was sent in formalin. And at this scanner view, you can see that there are pockets, multiple pockets of some lesion which would be obviously, you'll go on to the next slides. So this was the histology of those encircled areas. So here there is almost like a necrotic area which is kind of well defined, rather not well defined. They are having nuclear debris as well as neutrophils, which are following in a single pattern, which are encircling the deeper medullary tubules. So at the high magnification, what you see here is those garland of neutrophils which are in the vasa recta surrounding these tubules, so injuring the endothelial lining of these vasa recta. So this was quite diffuse in the entire tissue, and having the severe area of necrotic necrosis in the deep medullary region. So what you saw in the first scanner view. This again just to show the same findings of segmented neutrophils which are in the vasa recta. So this histology assigns to the entity called as a medullary angiitis. So the immunofluorescence luckily had two glomeruli. One of this is viable, which was negative for the immunoglobulin G and all the rest of the panels, and the tissue was reprocessed. There was one sclerotic glom, which on the special stain, the silver stain, revealed that it is indeed a fibrous crescent. This glom was unremarkable, and you can easily make out that the tufts are non-proliferative, and they do not have any necrotizing lesion or as such in this single viable glom. So basically, it's a case of medullary angiitis with the crescent, which is fibrous crescent in the one sampled glomerulus. So this is about the medullary angiitis, where Dr. Patrick Walker has come up with a large number of series of this medullary angiitis, which are associated classically with the ANCA lesion. Although in this patient, what I showed the renal biopsy, the ANCA test was negative, and some patients may also be of IG nephropathy, or rarely it could be an antibiotic treatment-induced medullary damage. So the index case, what we are looking at, and based on the immunofluorescence being negative, so we kind of get back to this table or the chart where based on the clinical presentation and the presence or absence of ANCA, where would this fit in? So although the tissue was limited and we do not have the information on the presence or absence of granuloma and the eosinophils, the likely bet would be that this patient would fit in this renal limited pauciimmune glomerulonephritis, or the chest symptom what he had, the cavitary lesion, would be of a systemic manifestation of pauciimmune glomerulonephritis, which is ANCA negative. The third case is that of a 58-year-old male who presented with unexplained renal failure with a creatinine of 6.8 milligram per deciliter, and the complements were normal, the viral markers were not negative. So this was the tissue that we were having. This is a scanner view there, and if you see that there is no glomerulus in this, but there are contents in these tubules which you would like to see at the higher magnification. This is a meson trichrome giving this crimson red color in some of these casts in the tubular lumen. So as you go into the medium magnification, you see these various shapes, and you can see a line here which is dissecting this cast at this magnification. And on the high magnification, you see that this is a PA stain, and you have this color of the tubular basal membrane, which serves as a internal control. Which you base your interpretation of that looks very weak positive, and you can see a rim of PS positive material which is encircling this larger amount of negative or weak positive casts. And similarly here, which is quite negative in the content of these tubular lumen. So as you look upon the mesotrichome, which is one of the best stain in this lesion, which gives a bright red or a crimson red color to all these monoclonal casts. You have this fractured cast, and they have different shapes. That's because of the angulation that this tubule would have imparted on the surface of this casts. So here you can see that it's fractured, and these are the ones which are usually the non-monoclonal casts or the tam-phosphol protein cast, which is seen in the tubular lumen of these in this patient. So in the immunofluorescence, you can notice that there is lighting up with the lambda immunofluorescent antibody, whereas negative with the kappa. So in this case is clearly that of a monoclonal light chain cast nephropathy with lambda restriction. So further to this, the patient would be evaluated for all the parameters of plasma cell dyscrasias, right from the CBC, the ESR, the bone marrow, free light chain assay, beta-2 microglobulin, and they have a staging mechanism after which they start the anti-chemotherapy, having the beta-2 microglobulin as a baseline or the free light chain assays as the baseline before starting, and see how the response is following in the following months. So next case is about a 58-year male with a nephrotic range proteinuria of 10 grams with presence of renal dysfunction. As you see, this patient is hypotensive, and again here at the scanner view, what you see here is a major chunk of it is the medulla, and a small portion of cortex is sampled. Basically, this needle has gone quite deep and has taken the medullary area. You can see even the urothelial in the highest magnification. Fortunately, this patient didn't have the complications related to this deeper tissue presence in the biopsy. So from here, these are the high magnifications, the photographs starting from the cortex here. These are the usual PS positive, and as you go down here, this portion of is represented in these two, where you see that the tubules are widened, set apart by the interstitial expanding lesion. And this was basically the same thing what you anticipate in case of amyloid deposition, and that it was seen in the tubular basal membrane as well as in the interstitium. Just like as any other plasma cell dyscrasias or in the amyloid, it would be a weak positive on PAS and the silver stain. This is the usual staining pattern of amyloidosis, and the congruent stain, the one which I was referring to, is the urothelium in this biopsy is here. The congruent stain here showing the birefringence in this relatively thicker portion, although you don't see the birefringence here at the lesser micron section in this portion of the tissue. It's more obviously seen in the thicker region. And in the immunofluorescence, there was no light chain restriction. We went ahead and did the IHC for serum amyloid A, and it was brightly positive in all of these interstitials. So this was about case of secondary amyloidosis based on these findings, but this case is a perfect case to be analyzed for apolipoprotein A4, because the amyloidosis associated with medullary predominant deposition is usually with this kind of a abnormality. So if we had the facility to do the mass spectrometry and analyze it further, then this is what we were very keen on looking in this case. So some learning points on the amyloid that I've learned during the practice here is whenever a patient is hypotensive and he has a nephrotic range proteinuria and happens to be above the age of 50, so your likelihood of anticipating the biopsy lesion as amyloidosis is almost 90%. And by chance, if there is a liver function test also done, and if there is a elevation of alkaline phosphatase, I'm certain that, I mean, this biopsy is going to show me the amyloidosis. Now, this learning is more for the pathologist rather than the nephrologist. They would be knowing it much better, but whenever a pathologist sees the clinician, the clinical form, to see what the presentation is, so these are the things which we should be looking at when you're analyzing the clinical data. And most of the amyloid is silver negative, but in case if you have the silver positivity, in the confirmed case of amyloidosis, it's going to be AL in my experience. I have almost around 10 or 12 cases where the stains would show that it is a positivity with a silver stain, and moving forward prospectively, the likelihood of it turning out to be AL amyloid is 100% as far as my learning goes here. I'm yet to see a silver positive and negative light chain restriction in the immunofluorescence. So just two words about the approach that all the pathologists should do is, in an elderly with a nephrotic range, never miss doing a congruent stain, because the early, it may look like a non-proliferative or a normal appearing glomerulus, but it could be the early sign or early deposition of amyloid in that case. And it's always prudent to do a thicker section. This is the only area in the renal pathology that one would do thick section to have that birefringence very much evident. Otherwise, it will be very difficult to pick up the birefringence. So the next case is about 36 years who is a post-transplant presenting with graft dysfunction and mild proteinuria. Again here, this is the available tissue with only one glomerulus at the deeper cuts. You're not able to see in the superficial cuts, but when we, as a routine practice, we do around 36 or 40 step serial sections, and in one of those there was one glom. And here at the scanner view, you can see that there is acute tubular injury in the tubules, and some portion of it is like scarring region. In the interstitium, there are few scattered lymphomononuclear cells, and at the higher magnification, this is the only lymphocyte which can be seen as infiltrating the tubules, calling it as a tubulitis. Otherwise, more or less, the interstitial inflammation was seen, and the peritubular capillaries also had leukocyte margination here, and the one glomerulus which was sampled in this deeper section showed the evidence of double contour in this region. You can see 2 or 3 capillary loops which show tram track appearance in a segmental pattern. So based on this, we can say that it is at least G1 score based on these leukocytes here in the capillary lumen with the swollen endothelial cell, and CG1B based on this finding, and the PTC2 which is evident here, the leukocytes, number of these leukocytes in the peritubular capillaries. So this would be assigned as a chronic active antibody mediated rejection by the presence of these linear positivity along the peritubular capillaries with C4D. So at least we could arrive at that the lesion is antibody-mediated rejection in this limited tissue. So the next case is that of a post-transplant who had a slow graft dysfunction. He is 8 months post-transplant. This is a scanner view, and in this there are 6 glomes, as you can see here. There are 6 glomes and 2 arteries are there. Not much of inflammatory component seen in this interstitial space. So at the medium magnification, one can see that there are infiltrates which are scattered in the interstitium and surrounding these vessels. More so here in a kind of lymphoid aggregates. And in this tubule, there is a mitotic figure which indicates that there is some kind of a regeneration going on. And on the right hand side, you see that some of these deeper distal tubules show inclusions within the nucleus. So this makes one to suspect that of a BK polyoma virus nephropathy. And this is the immunohistochemistry for SV40, which highlights these infected nuclei. So this portion of the affected by viral cytopathic effects was representing this portion. So for instance, if this portion was not sampled and we had only this much of renal tissue, based on the findings of interstitial inflammation and very occasional tubulitis, we would have misdiagnosed this as a borderline acute cell-mediated rejection. So it is always good to do the SV40 whenever you have a limited tissue, or even for that matter, the sampling issues to look for SV PK polyoma goes extensive in having 2 medullary 2 cores, which has a representation of medulla in both of the cores. Just about the classification of BK polyoma in this chart, we usually look for the inclusions and then confirm that with the IHC and look for the IFTA, that's interstitial fibrosis and tubular atrophy, whether it is 50% less than that or more than that. And based on that, we assign the staging. And if there is a very chronic tubulointerstitial damage, the chances of graft survival will go drastically down. But definitely in the stage 1 and B, with a lesser amount of chronic damage, there is a good outcome compared to stage C. So a few points on the decoy cells. The decoy cells, when you are seeing in the setting of post-transplant patient, when the urine sample is collected to evaluate for slow graft dysfunction, you have threshold for the decoy cells too low, so that you don't want to miss out a decoy cell and call it as there's no decoy cells, provided you have given the sample pre-analytical portion of urine sample collection, everything is in the right place, and the interpretation of your the decoy cells is negative, then it is going to shut the door for a BK polyoma virus further workup by the clinician. So never ever give a negative report without analyzing what is the pre-analytical portion in a given patient, because these are the viral cytopathic effects in the urothelium. They are very fragile, they lyse quickly. So if there is a delay in the transit of samples, then you might end up in calling it as negative, which the clinician thinks that it is urine is negative, so it's not going to have in the blood or the parenchymal damage. So that's the importance of urine decoy cells. So if, as you see here, the negative predictive value is 100%. That's why before signing it out as negative, you think about all the pre-analytical portion. This is another similar case where we had a BK inclusion, but only one glomerulus in this entire core. And as you see here, the viral load is quite extensive in this core. So the biopsy interpretation, the adequacy of the renal tissue goes on to say that the length of the core should be 1.5 centimeter, which basically is this cortex is almost 1 to 1.5 centimeter, and deeper portion is the medulla. So the needle goes through and through here and samples whatever tissue based on the angle of the needle. So the diagnostic entities or the morphologic predictors in the limited tissue. Here is a list what I have prepared that you would try to look hard in a challenging scenario when you are given with a limited tissue. So like membranous GN amyloidosis or ANCA mediated cast nephropathy, or the crystal deposition, BK polyoma, or antibody mediated rejection. So this is what I try to put in the case scenario basis. And of course, these are not diagnostic, but they give some information to the clinicians based on which he will triage further before doing a repeat biopsy, because this is a traumatic kind of procedure, and it involves a greater amount of counseling to the patient from the clinician that we may have to do a repeat biopsy. So I always try to look for if there is any finding that may help clinicians in further triaging. This one slide for the representation of biopsy material. We always look for number of glomeruli to rule out any focal lesions. So this is the list of gloms and the chance of missing the focal lesions, whether it may be a focal segmental glomerular sclerosis or a thrombotic microangiopathy. As an example, if we have 10 gloms, there is a likelihood of missing the lesion of focal process in almost 35% of cases. So that's the power of having number of glomeruli sampled in the given tissue. Location of glomeruli is also important, because some of the lesions like FSGS would begin in the glomeruli which are located in the juxtamedullary cortex, so in this portion. And also the number of step serials. I've shown you that the one in a case of antibody mediated rejection, the deeper cuts revealed one single glomerulus. So that's the importance of having more number of step serial sections, and also to pick up if there is any segmental lesion in a given glomerulus. So 8 or 12 cuts will not be sufficient to analyze the focal process. In the allograft, we need 10 glomeruli and 2 arteries. The minimum would be 7 and 1 artery. So yeah, this is a kind of scenario where the pathologist is very much happy that when you have a good number of cores, which altogether in this patient had 60 gloms, and in this child, in a single glomerulus there was 60 gloms. So the point I'm trying to drive here is in children, the interstitial space is still in the process of evolution, like the interstitial portion of is expanding. So that's the reason why there would be more number of gloms in even. I'm happy with 0.5 centimeter or 0.6. That would easily give me 20 gloms in case of kids, but not in the adults because of the wide displacing of the glomeruli by the tubulointerstitial compartment. So coming to another case of a 52-year-old male who has nephrotic range proteinuria and a normal renal function with having only hypertension. This in the hindsight of like the adequacy of tissue, if you are given less number of gloms, to call it as suboptimal. On the flip side, even more number of gloms also would be sometimes challenging to interpret. This is one example for that scenario, having a normal renal function and a nephrotic range proteinuria. So as you see here, scanner view, you have almost 16 gloms and most of them are dark in this silver stain. Only this glom is viable, and this is the capsular aspect. So the number of obsolete gloms are more here in the subcapsular region, what you see in this high magnification, and even in the deeper portion there are obsolete glom in this core. So the single viable glom here again shows non-proliferative tufts as well as thickening of the capillary walls, and there is some rarefication of the capillary wall here in this region. But in the immunofluorescence, there is lighting up of capillary walls as seen in a case of membranous glomerulonephritis. So to come at the diagnosis of membranous glomerulonephritis is made easy by virtue of this finding of thickened capillary wall and the immunofluorescence finding. But what about these number of obsolete gloms which are spanning in the subcortical zone and even in the mid-cortex, going in deeper region as well? So this patient is having a normal renal function. So we in isolation, if we don't read each of the clinical information which the nephrologist has given to you, you might call this as a chronic GN, chronic membranous nephropathy, based on the number of obsolete gloms which are quite deep. It's not just in the superficial, but these are can be misleading if you try to interpret just based on the pathology perspective. So the clinical information also needs to be put in while you are interpreting. So this is a membranous glomerulonephritis with superficial cortical scar, and I would like to bring in this article, which is a recent article which highlights the glomerular volume and the glomerular sclerosis in the various, usually we divide in the superficial cortex, the mid-cortex and the juxtamedullary cortex. So these three regions are different. This is a new learning for me from this article, which has commented about the glomerular volume, which is different in all these three zones, and the disease process also affects differently, especially in terms of obesity related glomerulomegaly and the diabetic glomerulomegaly, or the obsolescence because of the diabetes. So I would recommend to read this article, which is quite lengthy. It's almost 20-page article. Moving on to another last case in this session is that of a incidental mass lesion in the left kidney, for which nephrectomy was performed, and the non-neoplastic part was as you see here, and there were some of the tubular contents which on high magnification shows that these have a PS negative reaction, and the patient was diabetic. However, the histology does not show any obvious features barring the earliest lesion which can be picked up in the ultrastructure, but no obvious class 2 or 3 and 4 lesions of diabetes. But this definitely calls for a immunohistochemistry, because there was no fresh tissue taken at the time of grossing of this sample, and this was in the 2012, so we had no protocol for doing IF on paraffin section. So we went and did the immunohistochemistry for kappa and lambda, which shows that this is more intense with the kappa, although lambda is positive, but it is less intense compared to the kappa. So further workup was done in this case. The neoplastic part was that of a clear cell RCC with a nuclear ferment grade of 2, and the further workup showed that this patient indeed had more than 50% of plasma cells with a light chain restriction of kappa, with a skewed KL ratio and elevated IgG level. So the non-neoplastic portion in all the nephrectomies also needs to be diligently looked up for any parenchymal medical renal disease per se. So I have seen one. This is one case which we had presented in Mysore conference, and I have seen one more which Dr. Kiran had shared with me of a papillary renal cell carcinoma having amyloidosis in the non-neoplastic portion. Some references with regards to that. So basically, the gist of this, all the 8 cases in this Friday's was about how to handle or how challenging it will be when you are dealing with a limited tissue, or on the vice versa, when you are having adequate, that is even more challenging. How do you interpret in the clinical setting? You need to gather all the points from the clinicians and have a dialogue with him to explain each and every portion of clinical symptomatology or the syndromic presentation, and what is the reflection in the renal histology. So I am happy to take any questions now or at the end.
The beautiful presentation, Mahesha sir. That's what I can say. All pretty simple cases. Am I audible, sir?
Yeah.
All pretty simple cases, but everything leaves you a message, and every case had a message. So for a practicing nephropathologist or a pathologist, the amyloid stain in elderly, for example, you say like all elderly renal biopsies should be stained with amyloid, not to miss out on minimal amyloidosis. Or it's about step serials that can give you sometimes the pathological diagnosis, whether it's a transplant or native biopsy. Then relating to the adequacy criteria, like a pathologist should not get disheartened that there is no gloom, but the pathology may actually be in the medulla. And many a times the primary pathology is in the medulla when we do not even need the gloom to be interpreted. But it is ideal that we have the gloom, but that message is also very loud and clear that adequacy is case based. Like Dr. Mahesha said, adequacy is case based, the clinical scenario based. It should not be that we bluntly stamp something as inadequate based that glooms are not there or vessel is not there, but the pathology may actually be evident. And even like having one gloom is enough to diagnose certain like many disorders like amyloidosis or a diabetic nephropathy or you can say amyloidosis and MGM. They are very easily diagnosed even from one gloom. That's one message. And one more thing that I would again like to highlight is about the decoy cells. Sometimes people even mistake them as urothelial abnormality, epithelial abnormality. So there also the clinical scenario has to be taken into account, whether the patient is a transplant patient or it's a non-transplant patient, elderly patient on which we are interpreting the urine. So I would like the participants to ask some questions. In case you can unmute your mics, so you can ask to Dr. Mahesha or you can keep them to the end also. Sir, one question from me.
Yeah.
Sir, medullary angiitis, how often do you encounter? Like till date, I have been searching for it, but I have never able to come across such a thing. But how often do you encounter them as an entity in this ANCA-associated or this post-immune GN, sir?
No, it's quite rare. I mean, if I can recollect it, it will be in a single digit in the last 10 years. So it's quite rare.
Okay, because the case you showed was so beautiful, sir, that that around the tibius, that angiitis, that was like super. Like that picture is like that. That is like you can hang it on the wall and keep seeing it. It's so beautiful. That was really nice, sir.
Okay, thanks. Do we have questions, or we shall move on to the next 7 cases?
Sir, in the chat box, I don't see any questions, so I think we can move on, sir.
There is a question from the YouTube.
Yes, sir.
I'm just trying to forward that to Dr. Devashish, and on your WhatsApp I've just forwarded it.
Sir. So there are many comments, sir. Like people have congratulated you on the beautiful stains. And there is a crisp the pictures they are taken, and that is really nice. And there is a question also, sir, from Nabanita Das. Madam, she wants to ask you a question. Is there any crisp histopathological definition for ESKD?
No, it's a clinical terminology. ESKD is basically we are not going to touch upon the ESKD whenever you are interpreting. Like you are going to give a chronic staging on the histopathology. Whatever the tubulointerstitial or the glomerular compartment has chronic changes, that you are going to give a score. That's all is in our hands. So we are not going to write ESKD in our report. That's I would say we should refrain from using the ESKD terminology.
Absolutely, sir. Like, madam, I would also say same thing. Mahesha sir has already elaborated on that when we interpret a kidney biopsy, we take into the whole clinical picture, the serological profile, and then only we put our diagnosis. Still, we would always refrain ourselves to putting a death sentence for somebody, because that's you are saying that the kidney are no more functional and patient has to be put on some other artificial means of filtration or something. In fact, sir, Nabanita madam has also congratulated you. She liked the message of evaluating non-neoplastic kidney disease in and she has like to thank you regarding that one.
Thank you, ma'am.
Dr. Mahesha, this is Dr. Subro. I want to ask you one or two questions.
Yes, Dr. Subro.
Please go ahead, Subro.
So the first question is, when you have an early amyloidosis, which is where the congophila can be seen, but more often we cannot really document the under polarizing microscopy, the apellerin birefringence, because it becomes a little dicey. So what do you do? Is there anything that you do to circumvent that? That's my number one question. And number two, in one of your cases, I think in the case of medullary angiitis, there was one crescent that you shown, which was a fibrous crescent, which you could document in silver stain. So can you elaborate that? How could you distinguish it from an obsolescent glomerulus? These are my questions, and these are wonderful cases. I have nothing to say. I am kind of spellbound. Thank you.
Thank you, Dr. Subro. The first question is about the early amyloidosis. I would do a thicker section and do the congruent on thick section. That's the first part. And the second would try to do it by using changing the filter of the immunofluorescence to the red filter to see if there is any fluorescence there, or ultimately it would be the demonstration of amyloid fibrils in the ultrastructure, so would subject the paraffin block if there is no separate tissue for EM. So these are the three things that I would do if I am strongly thinking that this biopsy needs thorough evaluation for amyloid angle.
Right. Okay.
And the second question, like the silver stain which picked up the fibrous crescent, usually in the HND stain, it will be very difficult to dissect whether this is a obsolescent glom or a fibrous crescent, as you saw in that picture on the left side. The special stains would be of helpful for you to see how the extracapillary, that's the Bowman space, is occupied by and the underlying tufts. So in a given case like diabetic, when there is a accumulation of collagen within the inside of the Bowman space, so that also looks similar to fibrous crescent, which sometimes may be mistaken as fibrous crescent, but you need to see very little points in terms of whether the tuft is tuft to the Bowman space ratio of the whatever the pathology, that's the fibrous crescent is seen. I mean, in this it was difficult to compare with the other set of gloms because it was not there, but you always take the help of what's the other glom findings are. That is also very helpful in dissecting whether given case is related to ANCA or otherwise.
Sir, I would like to add one point for Dr. Shubro.
Yeah.
Shubro, I think whenever we suspect amyloid, I think even if we are not able to confirm, we should put it in our EndNote so that the clinician may investigate the patient further. Instead of just saying that it's negative, I think we should lead
Right.
them so that they can investigate or they can subject the patient maybe the biopsy for a EM, even if the tissue they have not taken at the initial time, and then they can confirm it through EM structurally.
Yes,
Right.
absolutely.
Good evening, Devashish. Can I talk?
Sure, ma'am. Please.
Chandra.
Please.
Yes, yeah.
You're welcome, ma'am. Please.
Pleasure to
Okay,
hear
okay.
you, man.
So
Have you here?
I thought, let me just make one comment in regard to what Shubro has asked. What I've observed over the time is that when you have this kind of problem of localizing small amount of amyloid, the best one mistake which we tend to do is we try to look for references in a bi-header or a multi-header. Never try that. Go on a mono header. You will definitely be able to show the birefringence. This I've seen practically in my routine practice. Whenever we are doing during reporting time, you won't be able to see it there. But since you need a very strong source of light, and if you go on a kind of mono header, you will be able to demonstrate. And I read
Wow.
this somewhere in one of articles. Somewhere I read. Then I tried this, and it really works very well.
Okay. That's wonderful, ma'am.
That's nice to learn.
Yeah, that's really nice to know.
Thank you, ma'am. Thank you, ma'am. Thank you so much.
Thank you, ma'am.
Okay.
Dr. Mahesha, you can continue. Sir.
Yeah.
There is one comment in the YouTube which I thought it's pertinent to share right now.
Yes,
Professor Kusum Joshi is there, and she said, "As perfect as ever."
That's like, oh God.
Thank you, ma'am.
Please carry on.
It's all what you have taught us. All the students, wherever they are under the care of Dr. Kusum Joshi and Dr. Ritamra ma'am. We always are in the.
We appreciate it, sir.
Thanks. So the next is a softy session that used to be held on Thursday at 4 in the evening. This is the most dreadful event a resident can have. Here, the resident would be on one side and the consultant would be on the other side of the table, bombarding with various questions pertaining to the slide that they have given on Tuesday evening, so that the residents would read and make some notes about it, and they would be quizzed on Thursday evening. So there are 4 cases in this. This is about a 24-year female. I'm just adding the flavor of all the activities in, so that it doesn't have the monotonous of case-based. It's some flavor attached to it. This is about 24-year female who has presented with edema and facial puffiness. So with a proteinuria of 2+ and 2.5 gram on estimation of the urine protein, with the rest of the things being normal, the viral serology, the rest of everything. So in the histology, some of the in the audience group, some of them might have seen this case in the conference when I presented this. So this is the low power magnification of the glomerulus, glomeruli in different stains. They appear to be enlarged in all of these glomeruli. The glomerular size is pretty big, and there is some abnormality in terms of having clear area and the cellularity, which is segmental in distribution in each of these glomerulus. Coming to the highest magnification of one representative photograph of this is in this PA stain slide. You can see that the material that is deposited here, which is completely occupying this stuff, which is vacuolated appearance. You can see the clearing of this region, which is completely obscuring the capillary tuft as well as the lumen, and the mesangial area is also some kind of a positivity is there with the PA stain, but not the crisp positivity that is seen in usual normal mesangial matrix. So in the silver stain, again this vacuolated appearance everywhere in all of these stuff. Apart from that, the capillary walls here do shows these holes or the craters in the tangential section of this capillary walls. So it kind of giving the appearance of that there would be kind of a membranous look in some of these capillaries. So segmental craters distribution is also seen. So in the immunofluorescence, this was with the IgG, where there was a non-specific positivity in a segmental distribution. Although at some places you can see that they have a granular pattern, but more or less it was nondescript in the glomerular tuft with the IgG, and rest of them were all negative. So this was a suspicion based on this vacuolated appearance. There was a suspicion that this could be a metabolic glomerulopathy, and based on the morphology, we suspected that this needs further evaluation in terms of LCAT deficiency. The ultrastructure of this case showed large irregular granular, both dark appearing at the periphery as well as clearing at the central portion of it in the basal membrane as well as in the subepithelial, subendothelial region, and even in the mesangial region, as you see here. So these were the electron dense as well as electron lucent particles, which is quite characteristically seen with the patients who have deficiency of LCAT enzyme. So further workup was done to look for all these abnormalities, and the lipid profile, which tells more about the lipoproteins that is involved in this case. As you see here, the lipid profile of this index case at the presentation when the biopsy was done and following at the 6 months interval, and the mother and father and the elder sibling was also evaluated for this to compare with the index case. You can see that the HDL was very low in this index case and normal in mother as well as father and the elder sibling. So HDL being so low, it's almost hits the diagnosis of this is a LCAT deficiency, and the bone marrow was also showing similar material deposition in the aspirates as well as in the trifine biopsy as one saw in the renal biopsy. And the further clinical evaluation was that this patient had in the whitish opaque, which is called as arcus senilis, along the periphery of the cornea, usually seen in this entity. So the Sanger sequencing of this gene was done, and there was a homozygous missense mutation for the index patient, although the heterozygous variant was seen in parents as well as sibling. So the heterozygote variation and a normal HDL in their blood. So this confirms that this is a case of LCAT deficiency, and this table is just to highlight about how do we tease the information on this fominess in the renal histology, and what are the differential diagnoses which one can anticipate in whether it is a crystal storing histiocytosis or a histiocytic glomerulopathy, which is usually devastating in terms of the FLH syndrome and affecting the glomeruli, or LCAT deficiency or ApoE glomerulopathy. So this table highlights about the differences in all these entities. So LCAT deficiency is a plasma enzyme which is very much required in handling of the lipids at the periphery of the tissues and sending it back to the liver. The deficiency is usually autosomal recessive, and the affected organs are the cornea, bone marrow, and the kidneys, liver, and spleen. So either the ophthalmologist would see this quite often, or a hematologist where the patient is evaluated for anemia. In some instances, the patient ends up in the nephrology department when the biopsy throws a light on what could be the further workup needed in this patient. So the second case is again in the same continuum. about another metabolic disease. He is again a 47-year male, no comorbidities in terms of non-diabetes, but he was hypertensive at presentation with 1 plus albumin and bland sediments, very less than a gram of protein leak, and he had grade 1 hypertensive changes. So at this panel, the striking thing is that of the Bowman space, where you could see that there is vacuolated appearance, which is better seen in the H&E stain than a PA stain here. The primary abnormality is in that of the podocytes, which are freely lying in the urinary space. So as you go into the highest magnification, then you see that the vacuoles are expanding the cytoplasm of the podocytes in almost each and every capillary loop which is surrounded by the podocyte has this vacuolations. Goes on to say that this is a podocyte vacuolation defect. So the first thing that we would think of is this kind of a Fabry's disease or a mimicker of Fabry's disease in terms of drug history. So this patient was male. In the immunofluorescence, as you see that there is negativity. The toluidine blue of this case, fortunately we had the separate core for EM, and this is the toluidine blue which shows this the vacuolation, what was seen in the histology is occupied by these swirling structures in the podocyte cytoplasm. These are more darkish in color, dark blue in color in this tall blue stain, and in the electron microscopy ultrastructure that these myelin figures were actually the ones which are occupying those vacuolated appearance. So basically in the formalin fixation and then the procedure of the routine processing, these things are not, these do not take up the stain in the H&E sites. That's how you get to see this vacuolated appearance. And these are the myelin figures which is almost nails the diagnosis as a Fabry's disease, and of course the enzyme defect would be given the primary diagnosis. This is a lysosomal storage disorder which is X-linked, and the lipids that is accumulated goes on to deposit in various tissues, leading on to corneal opacities, or sometimes they present with a renal failure affecting or even the LVH or stroke in earlier period of life. So, the key thing is to ask for detailed family history, whether there is any particular disease, the renal disease which is running in the family. So in the retrospect, this patient had a family history of all the maternal uncles being affected by the kidney disease. So he was fortunate to get funding for his replacement of the enzyme, and he is doing good. This one article about Fabry's disease, which gives us the perspective of how to go about in terms of doing the transplant in the patients who have Fabry's disease, and when to suspect the Fabry's in a setting of some systemic symptoms which has angiokeratoma or hypohidrosis. So on the both male as well as females who can be carriers as well. And in taking up the donors for end-stage kidney disease, usually the females can be silent carriers of the disease process, so that would run a risk of later on in the donor as well. So that's why the females are not taken as a donors unless it is the only donor. So the another case is that of a 54-year female who had chronic kidney disease running almost a year duration with a creatinine of 2. If you note this, there is no history of edema and the urine protein is 1 plus. So by this, the renal dysfunction without having any edema and the protein is 1 plus. So it's almost certain that this patient doesn't have any primary glomerular disease per se. So the tubular interstitial disease is the one what the clinician would think of in the given setting. The renal histology was a surprise for both of us, the pathology as well as the nephrology colleagues. That in this core, there were some of the tubular contents which appeared were quite dark or brownish in color, which are seen in the tubular lumen, and on the H&E stain, they are more of brownish in color. So as you see, these are arranged in a radial pattern in these tubular lumen, even eliciting some kind of a epithelial reaction surrounding these crystals, radially arranged crystals. And when you polarize this, you would see that bright birefringence, which goes on to tell that this is crystal deposition disease, which is affecting the tubular interstitium primarily in this given case, leading on to chronic kidney disease. So this patient is almost in the 4th or 5th decade. So this entity, although it may start in the beginning, but the presentation is quite late. Usually they come around 4th or 5th decade. The similar crystals were also seen in the macrophages. In the interstitium, they were loaded in these macrophages, and as birefringent, you can see these crystals much better here. And some of them are even seen in the tubular cytoplasm as well. So this is a PA stain which still retains the brownish color because of the crystal deposition, and the silver stain, which imparts this blackish color in these crystals. These are the staining differences. I'll come to the table later in various special stains. The trichrome stain doesn't really give any flavor attached to this crystals. They are more transparent here. And myself and Dr. Kiran, we summarized this as chronic tubular interstitial nephritis with numerous deposition of these 2,8 dihydroxyadenine crystals in the renal parenchyma, and further asked for evaluation, following which the genetic testing was done, and there was a homozygous mutation in this APRT gene. So this is basically a adenine phosphoribosyl transferase deficiency, which usually converts this adenine to AMP. In case of deficiency, then this is accumulated and these are secreted from the kidney, and this structure 2,8-dehydroxyadenine is insoluble in any sort of pH where you can't handle with just altering the pH. These are insaturable, and they form crystals in the kidneys. So this is a table to differentiate between oxalate crystals, as you see here, the right side picture on the H&D, and the same H&D from a different patient who has this 2,8-dehydroxyadenine, and here you can see that the brownish color as well as more transparent color in the H&D diagnosis, although you can easily make out that these are all crystals. So moving on to the another case, which is last in this section, is about post-transplant who had a primary graft dysfunction in less than a week. Is 20-year-old. The native kidney disease was not known. The donor is father. Was done in the anticipation of rejection, whether it is an antibody mediated or a cell mediated in a week's post-transplant case. But to surprise, the scanner view, as you can see here, there are some contents in the tubular lumen which are blocking the tubules, and on the birefringence you see this again, the birefringence, beautiful birefringent crystals which are blocking this. And this case was summarized as, you don't see the brownish color here, and as I showed you the table in the earlier slide, and these are the oxalate crystals, which is basically a recurrence in this patient, which might sometimes surprise you in the immediate assessment of immediate post-transplant biopsy. So this case was a recurrent recurrence of hyperoxaluria in this patient, and the genetic analysis also showed that he has a homozygous mutation. So these are about the 4 cases which were pertaining to the metabolic, 2 of them affecting the glomeruli and 2 in the tubulointerstitial, and can be sometimes surprising in the post-transplant evaluation. So any questions in this respect, you're welcome to, I can handle those.
Sir, I would like to make one point. In addition to this, we can sometimes come across a gout nephropathy, or we can say gouty nephropathy. So how often have you come across, or you come across gout in renal biopsy, sir?
Yeah, that's again one more addition to the list of medullary pathology. They are again needle shaped. We do come across with the gouty crystals, but nowadays the gouty nephropathy is the terminology should not be used. Earlier it was used as a gouty nephropathy, but it's basically a chronic tubulointerstitial disease with gouty crystal deposition once the saturation of urate in the serum goes beyond 7 milligram per deciliter. So these are morphologically, these are needle shaped and more seen in the medullary region. By reference, you can make out that these are different from the oxalate crystals.
Any other participant would like to ask Dr. Mahesha a question? Please, you're welcome to put your questions on the chat box, or you can directly unmute yourself and ask Dr. Mahesha, please. Dr. Mahesha, Dr. Ritambra has put a compliment for you, masterly class with a different style of conveying important messages. I absolutely agree with her. The message is very, very clear. A youngster, a young pathologist would not learn more than this from any textbook. I tell you, cannot learn more than this from any textbook.
Thank you, ma'am. It's all from you. What you have taught me is what I am doing right now. So, I'm just a messenger here.
Sir, I think we can move on to the next section, sir. There is no message in the chat box.
So next case is pertaining to the staff CPC that used to be conducted on Wednesday, 8 in the morning. This was done by the faculty on Wednesday morning. This CPC exercises in the PGI pathology has taught many of us who have been trained there, and we have been watching even through the social media, and we have learned many things from the autopsies that were conducted. So a large part of learning goes on to that autopsy room and the further evaluation of the cases. Similar to that, in keeping the same ethos, there would be more of a clinical pathology correlation in this. So next case is pertaining to that. I have a set of cases in this diagnosis who have presented with acute kidney injury and anemia with a proteinuria of 2+. One of them had peripheral hemolysis as well, and the creatinine was raised, one ranging from 7.93 to 11.3 milligram per deciliter. And all of them had acute kidney injury. So by definition, it is in terms of days, the deterioration of eGFR in these patients. It is irrespective of the age, like 18 or 23 or 36 at the age presentation. So, what you see here at the medium magnification is that of the glomerular as well as the tubulointerstitial, and the tubules have shown this cytoplasmic clubbing, indicates that there is acute tubular injury to a moderate extent, and some brownish color in the cytoplasm of these tubules, which is seen almost diffuse in this slide. What you see, the glomerulus seems to be okay, normal appearing in these two gloms. On the closer view, you see that these are very coarse, granular and brownish in color, occupying the cytoplasm of these tubules all over. And there was one of the area where there was thrombosis, which was in the venular segment. So in the kidney, like each compartment has some diagnostic clue towards the disease process. So in this case, it was more of a brownish colored pigment, and one solitary focus of thrombus here is within the venule. So, and the Prussian blue stain was done, and it was highlighting this as bluish in color, indicating that this is a ferric portion, that's iron pigment that is getting deposited, and not the lipofuscin, which is again brownish appearing deposit in the tubules as a wear and tear pigment. The immunofluorescence was negative for all the panel, and in the evaluation of hemocytosis, in the secondary hemocytosis, the classic teaching is that you evaluate for the paroxysmal nocturnal hemoglobinuria or the enzyme deficiency of the RBCs, like G6PD enzyme deficiency, or if there is any mechanical injury, like some patients may have prosthetic valves, and that would be the reason why the lysis is occurring, or sometimes the drug-induced rifampicin or vague heptanes would cause lysis of RBCs, and that would lead on to deposition of hemosiderin in the kidney, in the tubules. So the further evaluation was done, and in almost all of these patients, the flow cytometric evaluation showed that there is a deficient granulocytes of CD14 and CD59 in the RBCs, thus putting this case as that of a paroxysmal nocturnal hemoglobinuria presenting as acute kidney injury. And in the retrospect, all these anemia and the peripheral hemolysis would fit in as a variable presentation of PNH. So the classic teaching of PNH is like just like in this SLE, it can have various presentations. Similarly, in the PNH, it can have isolated anemia or pancytopenia, anything kind of drop in the counts of in the blood. So this PNH is the acquired clonal disorder, which is intrinsic membrane defect, and these are deficient in both these anchoring proteins, the CD59 and 55, and in the setting of this workup of hemosiderosis, this is the usual culprit. So G6PD is quite rare, and mechanical, of course, the mechanical injury is also one of the main factor that would come as a second in the order that we have encountered. So these are some of the references pertaining to this secondary hemosiderosis about affecting the renal parenchyma. Any question pertaining to this is welcome. This was about the correlation of the histology pigments with the clinical history, and then further workup, which completes the loop of the further assessment to be done in this case, highlighting the aspects that are to be covered post the biopsy findings. if there are no questions, I'll go on to the next, which is about the organ review, which used to happen on Tuesday, 9 o'clock and in the afternoon to thanks to Dr. Kirti for giving me this picture, the further slices of the brain. You might be thinking, why am I showing the slices of brain here? But the message linked to here is, again, I have a kidney which was not utilized in putting in the recipient, one of the kidney from deceased donor. So in that context, it's easy when a neuropathologist looks at the microscopic sections, sometimes that gives further clues to what this patient has. Although radiology in neurology picks up to a larger extent, but some things will be picked up by the histology and surprise both the pathologists as well as clinicians. So this is about the tale of deceased donor. This was a 39 years male who met with road traffic accident. This was in 2012, and following which he had hypertension, and the family agreed to donate the kidneys. The right kidney was not taken because he had abdominal injury, and even to one of the renal artery there was an injury. So they deferred this right kidney, and the left kidney was sent to another center, which was engrafted. So first I'll show you the right kidney, which was sent. Fortunately, the unused kidney was sent to histopathology, and this came 3 days later. The slides came, since it is a unused, I didn't hurry up in this case. So when the slides came on third day, I was literally taken aback, and to see this kind of injury in the glomeruli, I immediately called up the ZCCK, the concerned physician who deals with the organ donation, and asked, where is the paired kidney gone, and how is that patient doing? So as you see here, the glomeruli are all abnormal in terms of global as well as diffuse process in the capillary lumen. The highest magnification comes here, which shows that there is clots, the fibrin thrombi along with the neutrophils, which are clogging these capillary lumen. And there is hardly any capillary which is left by this process. So it's kind of a diffuse intravascular coagulation happening in this kidney. Just to show you the various stains and the pathology in this. And the left kidney was grafted in 36 years, male, who happened to have a delayed graft function. And the graft biopsy was done for DGF on 5th post-operative day. So I'll come to this histology as well now. So on 5th post-transplant day, he had biopsy done with a delayed graft function. The harvesting time was prolonged. So initially it was thought that this is the reason why he is having DGF. But on the histology, you see that there are some infiltrates in the interstitium, and on the closer view, these are lymphomononuclear, more or less of lymphocytes, which are occupying in the interstitium. So this definitely calls for a cell-mediated, and going on to the further, that these are even causing damage in the artery here, causing endarteritis. And one of the artery here, it's the panel, which shows that there is infiltration of lymphocytes beneath the subendothelium, indicating that there is endarteritis. And one of the glomerulus even showed that there is evidence of neutrophilic infiltrate with swollen endothelial appearance, causing glomerulitis. So there is acute glomerular as well as vascular and the cell-mediated rejection, and the C4D was negative. So none of these gloms, the fibrin thrombi which was seen in the opposite kidney, were evident in this glomerulus. So this was a learning point for me that no matter how extensive is the capillary thrombosis which is happening in the kidney in the donor patient, it's just it's kind of a diuresis once it's put in a new milieu. So when I looked up the literature, there were reports of donor-induced intravascular coagulation on the recipients, which goes on to say that the donor DIC was not associated with short-term suboptimal graft function, or which is defined as a slow graft function or the delayed graft function, and it's pretty much there in the retrospective cohort of 162 transplants and having the DIC in the donor. So it's absolutely fine to assess as a pre-implantation donor biopsy if there is a road traffic accident, and look for if there is any other pathology. If there are only microthrombi, then it is probably related to road traffic accident induced coagulation derangement, and that's fine, perfectly fine to take up the kidneys for doing the transplants. So in this two case reports, they saw that the further disappearance of this fibrin thrombi by 5th to 7th day, which exactly happened in our case also. Like on the 5th post-transplant day, which was the biopsy was done, showed acute rejection involving all the compartments, but the fibrin capillary thrombi were absent. And following this learning patient, we have quite a number of cases where we do get pre-implantation biopsies from the deceased donor who have met with road traffic accident, and this is the kind of fibrin thrombi which we do see, and the clinicians have taken up these kidneys and the patients are doing well, although there is a risk of delayed graft function in these cases, which is attributed. So there is a recent paper which says that there is a significant portion of these deceased donor DIC will go on for almost 28% will have a delayed graft function in this kind of scenarios. So this was about the learning from the microscopic evaluation of the unused kidney for whatever reason it was given to us, but it has a huge learning point to learn from and to continue the practice in evaluation of pre-implantation biopsies. So I'm left with one more case, that's the final one. Shall I continue?
Yes, sir. Please continue.
Yeah. The CPCs which were done on Monday, 8 in the morning, was usually done by the students, and the cases that used to be selected for student CPCs because of the lack of time there for the discussion, there were two cases, but learning points would be for the residents to engross usual cases like tuberculosis or cirrhosis. So those kind of cases were assigned in the student CPCs, but there were some little surprises, and I was fortunate to have some of the surprise cases to have presented in the student CPCs. To name few, Takaisus in 4-year-old child, and pulmonary capillary hemangiomatosis in the lungs, which are yeah. So next case is about the same as a surprise. This is about a 55 years female who presented with anemia and increasing proteinuria of 1.7 grams, which was slowly increasing for a period of 1 year. And she had anemia of HB of 6.7 grams with an elevated ESR. So urine routine had G plus of albumin and 25 to 30%. So SPEP evaluation and the ANA, everything was done in the serology, which was non-contributory. The ultrasound, the kidneys were of normal sized, and there was a past history of proteinuria following the intake of phenytoin for dystonia almost 1.5 years ago. So the histology was a surprise here, although the presentation is that of a subnephrotic range proteinuria. This was here at the scanner. You see that the glomeruli are pretty enlarged and they're almost proliferative. You don't see any capillary lumen here in any of these glomeruli. So the high magnification shows that the capillary lumen shows hypercellularity, and this hypercellularity is basically because of infiltrative cells which are coming from outside the kidney, which is in the circulation. And these description of these cells would be of a moderate sized nucleus with some having nucleolar prominence, a very conspicuous nucleolus here. And for the routine surgical pathologist, this is a easy cakewalk kind of case, but for in the kidney biopsy interpretation, this would take some time, not to jump in calling it as some kind of a vague lesion, but you would want to definitely evaluate this further. And this is the PA stain, which beautifully highlights the network of these normal glomerular tough compartments and the encircling these monotonous appearing cells. So these are basically monotonous appearing lymphoid cells which have a very high degree of mitotic activity, very brisk kind of dividing cells, and they are occupying the capillary lumen. Again, the silver stain gives you the good details of this nuclear chromatin, which is more or less the condensed chromatin in these lymphoid cells, which are monomorphic. So the immunohistochemistry, what we did was first we did we didn't want to waste the tissue, and first we did the CD3 immunohistochemistry, which came as negative, and the same slide was D-stain, and then we did the CD20, which highlighted these lymphoid cells as CD20 positive cells in these abnormally lymphoid population. And the Ki67, as you saw the mitotic figure, this was very brisk, high Ki proliferative index, and the PCL2 was positive in these lymphoid cells. Immunofluorescence was negative, and post-biopsy workup showed that the LDH was elevated. Based on the morphology, we thought of that this is a case of intravascular B-cell lymphoma, and asked for the organ involvement like the skin as well as the nervous system examination, which found out to be normal in terms of clinical assessment, and the CT chest was also normal without having any lymphadenopathy, whether in the internal or the external lymph nodes enlargement. So this was summarized as an intravascular B-cell lymphoma, which is kind of a rare form of diffuse large B-cell lymphoma, often fatal, and thus it is diagnosed at the autopsy. Very occasional, it can be seen as a renal biopsy surprise, or sometimes in the central nervous system when there is any biopsy which is done. I don't think this would be the perfect for doing a biopsy, but of course the renal or skin dermatology manifestations, yes, definitely there is a scope for biopsy, and usually these patients present with the B symptoms, and as I said, it's quite aggressive and fatal without any immediate intervention. Less than a year survival is hardly any 20 or 30% without any treatment. So this is about the intravascular B-cell lymphoma. It's basically the defect is in the homing of these abnormal lymphoid cells. So they lack this CD11 or some ligand which seeps into the lymphoid tissue, and thus it just goes on circulating everywhere. The usual organs are kidney, skin, and the CNS. So with that, I end with this slide saying that whatever the disease may be, the presentation is usually the proteinuria, the hematuria, or the drop in EGFR. So there is a lot more to look in various angles. So it's good to see the slide unbiased with the clinical information, and then again re-evaluate with the help of whatever the clinical information that is being provided. So it's just putting all the things together, clinical, the light microscopic findings, immunofluorescence, and then electron microscopy to arrive at some sort of reasonable clinical pathology correlation, and you're done with it. Your job is done once you put in all these three. So this is the Mysore Palace, and during the lighting session, it would simply look like this. With that, I end my talk. I'm happy to take any questions. So I'm sorry I kept you so long. It's almost like 1 hour 45 minutes.
I would like to congratulate you on such a beautiful presentation. The last case was as big as a surprise for me as was one of the cases that you had showed me with the microfilaria in one of the glomerular tuft. I don't know whether you remember that case or not, but yes. I had seen that in your lab with the microfilaria. That was as big a surprise. I like the one, that intravascular lymphoma. So there are some compliments for you, sir. And Dr. Anita, she wants to say that thank you for presenting these beautiful cases. Dr. Ravindra Prabhu, he wants to congratulate great series of cases. And Dr. Anand Bardia, one of our juniors from PGI, he wants to say thank you, sir, for all the outstanding cases. And there are a couple of comments from YouTube also, sir. Navita Das madam, she wants to say that thank you for such a good and educating seminar, sir. It had all the flavors of PGIMER academic activities, and that makes me proud too, sir.
Thank you.
So if somebody has a question, please unmute your mics and you can directly ask to Dr. Mahesha. Nadim sir, maybe you can put up a few questions if you want.
I don't qualify to ask questions to Mahesha. I can only, I don't think so there are any questions. There's only one more comment in the YouTube. Kirti says, great collection of cases. That's Professor Kirti from PGI. I completely agree with what Dr. Nabanita said. It had all the flavor of the weekly academic jargons which we all go through from Monday to Saturday in the reverse order, and very nicely presented in a very nice manner, and trying to put things in perspective, starting right from Saturday, the journal club, right up to Monday, the student CPC. So it is a very unique way of having a slide seminar, which brings in a lot of flavor, as well as it brings in completely a different groups of activities which goes through, and case based on those groups of activity. Wonderfully done. Dr. Mahesha reminds me of you can say Rahul Dravid. So steady wall, which is so perfect and so clear.
Sir,
he exactly knows what he's doing.
Nadim sir, a batsman who can face 600 deliveries to score 200 runs.
Yes, so you
He's
basically...
like a wall. He's like a wall.
Yes, and Dr. Mahesha is like a wall in nephropathology. You can see that, and the gamut of cases which was shown,
And all cases had a message. Beautiful.
Very. It is going to be a big learning material for everybody on the YouTube. We shall be sharing the recorded YouTube for everybody to listen to it and learn from it. There is so much to learn from this. I can't imagine, how helpful it will be for all the postgraduates, the FRC path players who are waiting to appear in the March exam, which is on the way. Thank you so much. And I don't think so that there are any questions. Thank you, Dr. Debashish, for taking all the trouble of moderating this session and adding your own experience to this. So wonderfully done. Thank you so much.
Thank you, sir. Thank you for the opportunity.
Oh, it's always a pleasure. It's always
Sir,
mine.
one last message, sir. I would like to read out. Dr. Shubhradip has congratulated sir, and he has told simply outstanding. Many such cases are seen in autopsy. Thanks a lot.
Yeah, thanks, Subro. I think you're referring to the last case that.
Yes, absolutely.
Serial lymphoma. Correct. Yeah.
Yeah. Before we close the session, I would just like to announce that we have a talk tomorrow. And this is at 8:30 after this cytology golden talk. I think people should be very much interested in this. It is immunohistochemistry and molecular profiling of brain tumors by Dr. Shilpa Rao. This would be very interesting for all the neuropathologists, right from nephropathology. We move into neuropathology tomorrow, and that would be very interesting. So, with that, I think I thank everybody for participating in this. We had a big crowd in YouTube and a very big crowd in Google Meet. And before I close, let me once again thank Dr. Mahesha. Thank you so much for consenting to taking out time and presenting such wonderful cases, sharing your knowledge. You have astounding knowledge in nephropathology, and thank you for sharing that. Just before closing, Dr. Rajiv Shukla from Liverpool, excellent. I will watch at my leisure. So you have people, all across. And definitely by tomorrow morning, the entire Far East and the Europe would have seen your lecture on the YouTube. And we'll be receiving comments from there. I'll be putting it up to you as well. Thank you so much, everybody. God bless you. Thank you so much. Good night. Take care. Bye.
Thank you, sir. Good night. Good night.